The mission of Allergy and Asthma Network is to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. This is Sally Schessler, Director of Education for Allergy and Asthma Network, and it's my pleasure to welcome you to Advances in Allergy and Asthma. This webinar series is presented in partnership with the American College of Allergy, Asthma, and Immunology. Today, I am pleased to introduce Dr. Jeremy Katcher, who will speak to us today about the September Asthma Peak. After completing residency at Virginia Commonwealth University in Richmond, Virginia, and an allergy immunology fellowship at the University of Tennessee, Memphis, Dr. Jeremy Katcher has been in allergy practice in the St. Louis, Missouri area since 2010. Currently, he is in practice at Gateway Asthma and Allergy Relief, a division of ESSA Health. He is a member of the Quad AI and a fellow of the American College of Allergy, Asthma, and Immunology, or ACAAI. He has been actively involved in the college with current positions including ACAAI Respiratory and Sleep-Related Breathing Disorders Committee Chair, Annual Meeting Program Committee member, where he also serves as Asthma Committee Annual Meeting Liaison and is a member of the Scientific Council and Member Website Committee. Dr. Katcher, thank you so much for being with us today. We're looking forward to learning something new from your presentation.
Thank you, Sally, for that introduction. I'm very happy to be here today to speak on this important topic and hopefully help prevent some asthma issues among our pediatric patients. The learning objectives today will be number 1, to define and describe the September asthma peak. Number 2, review mitigation efforts to prevent September asthma exacerbations. And number 3, to review updated asthma guidelines, especially pertaining to school-aged children. As most of you already know, but just to review, asthma is a chronic inflammatory condition of the airways in the lungs. The prevalence is estimated to affect approximately 300 million adults and children worldwide. Common symptoms can include cough, wheeze, shortness of breath, and chest tightness. Triggers of asthma can include allergies. And when we talk about allergies, we're talking about tree, grass, or weed pollen, mold spores, dust mites, or animal danders, most commonly, although there are other more uncommon allergens that can trigger. Exercise, upper respiratory infections, strong odors or fumes, smoke or pollution, stress or anxiety, strong emotion, and even laughing. Treatments are directed at decreasing airway inflammation and relieving symptoms caused by narrowing of the airways. So what is this September asthma peak? It's been witnessed for many years that asthma exacerbations in children increase and are at their highest levels in the early fall, typically in the month of September. This is actually a global phenomenon, believe it or not, with literature reported in North America, Europe, even the Middle East. Interestingly, this occurs in the Southern Hemisphere as well, although this typically occurs in February. And if we think about it, that makes sense since our seasons are the opposite. So their winter is our summer and vice versa. Why does the September asthma peak occur? Well, there is a strong association between the timing and the return to school after summer break. Contributing factors include medication non-adherence over the summer, stress involved with returning to school, indoor allergen exposures from school, which can include dust mites, mold spores, or even animal danders that children bring on their clothing, outdoor allergen exposure, and in my neck of the woods in the Midwest, that often takes the form of mold spores and weed and ragweed pollen, humidity and pollution and poor air quality associated with the the September time of year, and most importantly, viral infections acquired upon returning to school. Typically, children get infected at school, and then they bring home the infection to parents, and there can even be a delayed peak in exacerbations among asthmatic parents of these asthmatic children. The age group that is affected the most is typically the 0 to 4-year-olds, followed then by the 5 to 9-year-olds, and then it seems to level off thereafter. There's a figure on the next slide that will illustrate this. Similar to overall asthma demographics, there seems to be a higher burden among males in the prepubescent years, but the burden is worse for females after puberty. As mentioned, this graph illustrates the rate of asthma exacerbations with emergency department visits corresponding with the time of year and patient age. As you can see, the highest peaks do seem to occur around the months of September. This graph shows a depiction of the years 2003 to 2013, and you can see the highest peaks do tend to fall in September. Additionally, the blue line corresponding with the 0 to 4-year-old age group is clearly higher than the rest, with the purple line under that corresponding to the 5 to 9-year-olds, and then the two lines on the bottom, blue and what looks like an orange, no significant difference for the older children. So what are ways that we can prevent this September asthma peak? We take a multi-tiered approach. Number one, medication adherence is key. It's important that all pediatric asthmatics take their medications preventively. How can we ensure that that's done? We have to figure out routines that they can get in to remind them. For example, I'll oftentimes tell my patients, put your inhaler next to your toothbrush in the bathroom as a reminder to use it twice a day, hoping that they, of course, brush their teeth twice a day. If it's a once a day inhaler, also that would work to say, do it before you brush your teeth in the morning. This also helps remind them to rinse their mouth out after the inhalers. For the older kids and adolescents, we like to harness the power of digital technology. So if they have a smartphone, I'll oftentimes recommend set an alarm on your smartphone for the 2 times a day that you should be taking your inhaler. Something that will remind them every day to take it. Recently, actually, there's an inhaler product line that has come to market that actually uses an app on a smartphone, and that app interacts with the inhaler to help with reminding to take the medicine, keeps track of how many times it's taken, and actually gives feedback on inhaler technique. Speaking of technique, that is another component of medication adherence, because if we're not taking the medication correctly, the medication isn't working. This is a lot harder for inhalers than it is for swallowed medicines. For example, with a swallowed medicine, we swallow it, and then our GI system digests it and does all the work for us. With an inhaler, we have to make sure that the inhaled medication gets into our lungs, and therefore technique is important. When we're talking asthma inhalers, we have 2 different types, primarily a dry powder inhaler, and then our hydrofluoroalkane, or HFA, or as I'll refer to it kind of as a puffer inhaler. Both have their pros and cons. Dry powder inhalers typically require less coordination. However, they do require more forceful inhalation. And so in my practice, I tend to discourage these among younger children just because they don't usually have that forceful inhalation yet. Additionally, sometimes dry powder inhalers, at least some of the older ones, can tend to irritate the throat a little more. The HFA, or puffer inhalers, tend to require more coordination to use by themselves, but tend to irritate the throat less. Many providers, including myself, especially for children on these puffer inhalers, tend to recommend using a valved holding chamber. And what this does is it helps negate the need for that coordination using the puffer inhaler and allows more of the medication to get into the lungs where it needs to go and not just hit the back of the throat, especially if the coordination is not ideal. For the younger children and infants, nebulizers are often used. And this typically does provide good deposition of medication into the lungs when used correctly. Definitely for infants and toddlers, a face mask would be used. As kids get older, they may be able to use a mouthpiece. It's important that if you're using a mouthpiece to make sure that they are breathing in and out through their mouth. I do want to mention that some infants and toddlers who don't tolerate a mask, sometimes parents will try what's called a blow-by method, where they put the mask or mouthpiece near their face while they're sleeping in an effort to try to get them to breathe in some of it. I don't believe there is a whole lot of evidence that this strategy works well to deposit medications to the lungs, so it is not recommended to use the blow-by method. Online, for example, YouTube, there are resources to help with good technique using an HFA inhaler with a valved holding chamber. I will mention that valved holding chambers do come with two ways of fitting the face. One is with a face mask and one is with a mouthpiece. You can see the picture here depicts a mouthpiece. For the younger children, toddlers up through about age 5 to 7, depending on the child, I oftentimes will recommend a face mask. And then once they get a little bit older and can understand what they're supposed to do with the mouthpiece, I will then tend to transition to a mouthpiece. With a face mask, typically the instructions are puff one spray into the chamber and then take 5 to 6 deep breaths, being sure that there is a good seal of the mask around the face, over the nose and the mouth. As opposed to with a mouthpiece, as you see, it just involves one puff into the chamber and then a slow, deep breath, and then holding the breath for 5 to 10 seconds. There are also resources on the National Jewish Hospital website as far as illustrations on inhaler techniques. As we're talking about preventive strategies, we have to mention hygiene, since upper respiratory infections are certainly a very prominent cause for exacerbations. So we are all very aware of hygiene recommendations these days as we're in the midst of a pandemic. So hand washing, warm water and soap, certainly very important, doing an adequate job. Hand sanitizers also are heavily used. I oftentimes recommend my pediatric and adult patients, for that matter, do not touch your face. How do we transmit germs and acquire upper respiratory infections? From surfaces that we touch with our fingers, and then our fingers then touch our mucous membranes, eyes, nose, mouth, and that is how these germs gain access many times to our upper respiratory tract. Of course, masks are very prominent these days, and hopefully, eventually, masks will not be as much of a major part of our lives, but I have to ask, will they be an optional part of our lives? It's been clear that typical upper respiratory infections have decreased during this pandemic, and have to assume that part of that reason is masking. Certainly social distancing at times has made a difference, but will they play a role for the most at-risk asthmatics? We'll see. Certainly trigger avoidance, your allergies, irritants, we want to avoid those as much as we can. And then taking a proactive approach with your asthma provider. So we recommend seeing your asthma provider, either right before school starts or at some point over the summer to get a updated assessment. And with these assessments, there's subjective assessments provided by the parent and the patient with the asthma control test, where you fill out your symptom frequency, and that gives us some idea. And then there's objective measures that we can do in our office, such as spirometry or peak flows, to see what is going on in those lungs. So as the provider, we would then provide a specific and documented action plan where we talk about preventive medications and what to do in the event that asthma symptoms do develop. Most asthma action plans out there are fairly standardized. This is a picture of the one we use in our office. They all kind of involve a green zone, yellow zone, and red zone. The green zone, this is where patient is doing well, they're taking their preventive medications regularly, and their asthma is doing great. So it's essentially just take your preventive medications. Yellow zone, well, this is when we're developing asthma symptoms. What do we do? So we have symptoms, we take our albuterol as illustrated, and hopefully this does the trick. If the albuterol has to be taken multiple times and symptoms are not doing well, not getting better, or if symptoms get worse, well, then we enter the red zone. Red zone is where we're having serious asthma symptoms that are not typically responding to the usual care. So this is an urgent medical situation. We need to seek medical assistance urgently. We give higher than normal doses of albuterol, and certainly if there is a steroid on hand, we get that in as soon as possible because that can take a few hours to start kicking in. But when we hit a red zone, that's not good, and that's what we're trying to avoid. I will note that the Quad AI website has a SAMPRO asthma action plan that can commonly be used. It is available in English and Spanish. It was developed by a collaborative group of doctors, school nurses, and asthma experts, and it's customizable. You can add your logo to it if you need to. Okay. Last section of our presentation is to discuss some of the updated asthma management guidelines that do involve children asthmatics. These guidelines came from the National Asthma Education and Prevention Program Coordinating Committee Expert Panel Working Group, and again, this was updated in 2020. So the first recommendation for children 0 to 4 years old who have had 3 or more episodes of wheezing triggered by upper respiratory infections in their lifetime, or 2 such episodes in the past year, and are asymptomatic otherwise. So essentially just these upper respiratory infection triggered patients. The panel recommends episodic inhaled corticosteroid for 7 to 10 days at the first sign of upper respiratory infection, with as needed short-acting beta agonist, albuterol, for example. And this approach was preferred as compared to just using albuterol as needed alone. After reviewing the data, this resulted in a 33% relative risk reduction in systemic steroid use. Next recommendation, for individuals 12 years and older with mild persistent asthma, defined as symptoms at least 2 days per week, but less than daily, options could include daily low-dose inhaled corticosteroid with as-needed short-acting beta agonist, or you can use the inhaled corticosteroid with the short-acting beta agonist on an as-needed basis. There were no recommendations in the 5 to 11 age group, as this regimen had not been adequately studied. Next, in patients greater than 4 years old with mild to moderate persistent asthma who are adherent to their inhaled corticosteroid, There was not good evidence for or against increasing the inhaled corticosteroid dose short term when there were increased symptoms or decreased peak flows. I can tell you over the last several years, there have been unofficial recommendations and allergists and asthma specialists that do employ this strategy, where if somebody gets a cold or somebody has an increased symptom time, we would say double your inhaled steroids or quadruple even your inhaled steroid dose. So what this updated guideline is saying is that we don't really have good evidence for or against that strategy. Next, in patients greater than 4 years old with moderate to severe persistent asthma, inhaled corticosteroid and formoterol in a single inhaler used as both daily controller and reliever therapy, which is termed SMART therapy, single maintenance and reliever therapy. This approach was recommended over using higher dose inhaled corticosteroid controller with as needed short-acting beta agonists such as albuterol, or the same dose inhaled corticosteroid and long-acting beta agonist controller with an as needed albuterol. Essentially, using the inhaled steroid and long-acting dilator both as your preventive maintenance and as your rescue medicine. Theoretically, the formoterol does open the airways, much like albuterol, and then the additional doses of inhaled corticosteroid would further decrease that inflammation in the airways that would be contributing to this increased symptoms. This approach has been shown to decrease exacerbations and systemic steroid exposure. Maximum total daily dose of the formoterol should not exceed 8 puffs for ages 4 to 11. So that allows for 4 more puffs throughout the day if needed. And it shouldn't exceed 12 puffs for ages 12 and above. So that allows for 8 more puffs during the day if needed. I did want to note that in the US, the FDA has not approved these medications for this strategic use. So though there's good data to support that it works, there could be some issues with payers and insurance covering it, especially when somebody were to go to refill it too quickly. So if they're using it more than 2 puffs twice a day, it's not going to last a full month. So you may get some pushback by payers. So hopefully in the future, we may get some budging on this from the FDA, but as it stands now, not approved as far as I know. In summary, the September asthma peak results from a combination of seasonal factors and accounts for increased asthma morbidity and healthcare utilization and expenditures. There are strategies to help minimize all the pediatric asthmatics' risk. Work with your asthma provider to develop a comprehensive and preventive asthma plan. And as I just reviewed, there are new asthma guidelines that do provide evidence-based strategies that can help. Here are my references listed. And at this time, be happy to take some questions.
Wonderful. Thank you so much, Dr. Katcher. We have questions ready to go for you. So our first question is, can you explain why it is important for adults and children to continue taking daily asthma medications during the summer months, even if they are not experiencing as many asthma symptoms at that time?
Absolutely. It's a good question. So if we remember what is causing asthma, what is asthma? It is an inflammatory condition of the airways that when the inflammation gets too high or the inflammation with an additional trigger occurs, then it causes those airway smooth muscles in the airways to spasm or narrow, and that narrowing causes restriction of airway flow through those airways. And so since the inflammation we want to keep at a minimum once we get back to school and are likely to see upper respiratory infections, which often act as that trigger, it's important that we do what we can preventively. So keeping that inflammation at a minimum, even during the summer, will help theoretically raise that threshold of triggering an exacerbation once that exposure is encountered, most commonly upper respiratory infections upon returning to school.
Thank you so much. What are some practical strategies or tips to help people, especially children and teens, stay on asthma medication schedule during the summer months?
This can be challenging. Summertime is a time where schedules are not as rigid and routines can be lost. My recommendation is try to preserve those routines as much as possible. Associate taking the preventive medication with something that is done every day, regardless of time of year. I oftentimes recommend to my patients, put your inhaler by your toothbrush, and as a reminder to take your inhaler twice daily before brushing your teeth twice daily. For older children and adolescents who typically at this point have smartphones, I take advantage of that. I recommend set an alarm on your smartphone to take your inhaler twice a day or once a day if it's that kind of inhaler. There is additionally a recent product line that also uses an app on the phone that is interactive with the actual inhaler. So that's another avenue that can help remind a patient, especially one older with a smartphone, to take their medication consistently.
Thank you so much, Dr. Ketcher. Another thing Allergy and Asthma Network often recommends is we have an asthma storylines app that can be of help with remembering to take medications. So if you go to our website and look for the Asthma Storylines app, it's a free app, and it tracks more than medications and can really be helpful when children and students and youth go to the doctor's appointment. They can have a lot of information for the doctor in the app. So I think apps are certainly going to be a way of the future, especially with that younger generation.
I agree.
Okay, our next question is, you recommend keeping an inhaler near a toothbrush for a reminder, but isn't a bathroom with its inherent humidity bad for DPIs?
In theory, it's not ideal. So potentially putting it in a more you could put it in a more sealed container as or a Ziploc bag to lock the humidity out. But the point is well taken. But to be honest, if it's a matter of not remembering, I will take the humidity risk over not taking the medication. So, but I think there are these little mitigating efforts, putting in a Ziploc or some kind of sealed container where it would not be as exposed to the humidity.
Okay, the next question has something to do with peak flow meters, and there's been a lot of controversy that I've seen about whether or not people recommend the use of a peak flow meter. So the question is, do you routinely recommend a peak flow meter?
In my practice, I gauge it on a patient and a parent's comfort level. It's not a uniform recommendation, so I take it on a case-by-case basis. If a patient or parent wants to keep track of their asthma on a very tight basis, then absolutely I work with them and come up with their baseline and advise them to measure it regularly. If on the other hand, they are not motivated to do that and the asthma is not severe or moderate to severe, then I don't necessarily always use it, but it is a tool that we do employ. And you're right, there is a lot of variation in how allergy and asthma specialists use or don't use peak flows. So it's a good question. I don't have a perfect answer for you, but they are still used to some extent.
Okay, thank you. The next question that Margaret is asking is the asthma action plan in your EMR, your electronic medical record?
Ours is, we have a template that it makes it really easy. The medications load up. They have the standard albuterol phrasing and just a couple clicks and it pops right up. A lot of EMRs do have that, but if you don't, then these are easily accessible online, again, at the Quad A website, or lots of other websites too, but they all kind of have a standard format, green, yellow, red. But yes, ours does populate on our EMR.
Oh, that's got to be very helpful. Okay, our next question is, what is your opinion on parents who request a doctor's note to exempt their child from wearing a mask? Are notes written only if the practitioner determines this child is at risk of breathing difficulty, or is it mainly based on parent request?
In my practice during this pandemic, that has been challenging. There are some patients that do complain of increased shortness of breath with wearing a mask. And what is causing that shortness of breath is the question. There has not been any evidence that mask wearing decreases the oxygen level in the blood. There's not been any evidence that it decreases any oxygenation in the lungs. So specifically for asthma, the masks, from the data that we have, the masks don't seem to affect asthma. The question is, so then why are they perceiving this shortness of breath? And that can be potentially an upper respiratory issue. With asthma, sometimes some people have a little bit of upper respiratory involvement, like in their larynx or their right in the deeper part of their throat, that can become sensitive and can tense up. So there's probably some component of that, potentially a component of anxiety, and if they're accustomed or have history of feeling short of breath, then that breathing limitation can trigger some feelings of anxiety, which acts as a makes things worse. So I have really tried to educate my patients about this when it is brought to my attention, and really try to recommend working through it using some abdominal breathing techniques to try and ease some of that tension in the upper airway. But because, well, I should say, even though asthma has not been shown to be a major risk factor for severe COVID, we still want to take care of our asthmatics. So I would hate to leave somebody unprotected if I can avoid it.
Okay, the next question, you and I can both help to answer. The question is, what is SAMPRO? Do you want me to start, or do you want to start on this?
You're welcome to start. I don't recall the exact acronym, so I'm going to defer to you on this one.
No problem. SAMPRO stands for School Asthma Management Program, and this was kind of the brainchild of Dr. Robert Lemansky of the University of Wisconsin when he was the Quad AI president. He decided to work with the National Association of School Nurses, so it was a really joint effort to develop some really sound school resources. And what was really neat about how they went about it is that they had national physician experts, they had national nursing experts, they had national school experts, they had parents, they had all sorts of stakeholders all in the same room. And I had the privilege of being one of those people in that room. And we broke up into work groups, and where some people worked on the action plan and other people worked on policies. And we really put together a really comprehensive program for schools. And you can find it by just literally Googling SAMPRO asthma, and it'll come up, and you do have to put in your name and email address, but this is at no cost to you. The resources are just there. They're in English, they're in Spanish, and the asthma action plans can have the logos on them, or you can use them plain and put your own logo on them. They are fillable forms. I am all about this program. I just think they went about it being developed in such a great way. They listened to every stakeholder. You know, one of the other things I love about the Asthma Action Plan is it also has a spot at the bottom where it can become your medication permission. So it's one less form that you need. And so I really would encourage people, you know, Google SAMPRO and asthma, and you'll find these great resources that you can use in your school. Do you have anything you'd like to add to that, Dr. Ketcher? Or is
That
that
was
it?
perfect.
Okay. Well, I get very excited about it. It's like I have to, you know, take a step back and take a deep breath because it's just a really great resource. So the next question is, can we get a copy of the PowerPoint slides? And I'm afraid the answer to that is no, because this is being used for continuing education credit. So, but what you can do is you can access a recording of the program if there's something that you wanted to see again. Okay, our next question. Are you seeing your patients mention the prevalence of wildfire smoke?
I'm located in St. Louis, and I actually have not had one single patient mention that to me. Now, I will tell you, on occasion when I've gone outside, we do get these periods where it's definitely hazy, and you watch the weather and they say that's because of all the smoke coming our way. But interestingly, I've not had a patient bring that to my attention, but your question brings up a good point, which is that smoke, even if it's halfway across the country moving into our area, can affect the air quality and can be a risk factor and a possible trigger for asthma exacerbation. So your question is noted well, but interestingly, no, I've not had a patient ask me that.
So the CDC does have some excellent resources on wildfire smoke and respiratory issues. So if you're concerned with wildfire smoke, that might be a really great source of information for you. Okay, here is every school nurse's big question as they enter the 2021-2022 school year. Is nebulizer use advised in school buildings during the pandemic?
Wow, that's a loaded question.
But it's a struggle for the nurse. And so if you can
Absolutely.
offer any insight, it will be appreciated.
I will tell you that is even a controversy in our professional allergy organizations. There is no official stance on whether to use nebulizers in our offices even. So I think everything has to be taken with a risk-benefit calculation. In our practice, I will tell you, we have not done nebulizers since the pandemic. But we do pulmonary function tests with some precautions. So every practice is different. I would say preferable until the pandemic is somewhat more under control. I would certainly try an inhaler first. But if somebody is in distress and is not responding to an inhaler, I think there are precautions to be taken. Maybe put them in a room by themselves where there's doors closed and less communication with everybody else. And you may have to do what you have to do. It's hard but I can't give you a formal guideline or stance because it just doesn't exist.
Yeah, I think this is something that's going to be very interesting for every school district to really decide what they're going to plan to do. I know of some school districts that have talked about that if a child had reached a point with their asthma that they needed a nebulizer, that they were going to ask the parents to take them home, do the treatment, bring them back. So that would be an option. But I know a lot of school districts are trying to figure out how to do this well. And now it's my understanding that the virus can stay in the air droplets for 3 to 4 hours. Do you know if that's correct?
I mean, they do stay. I don't recall the exact time frame, but they don't just go away quickly. So there definitely is some degree of a risk of droplets staying in your vicinity when using a nebulizer. So again, try to minimize as much as you can, keep it in a secluded area. Consider, I don't know what the resources may be, but an air purifier in that area, and hope for the best. But again, if somebody is an extremist and you don't have really much other choice, you got to weigh the cost and benefit. The other thing I will mention, as if you were just absolutely trying to avoid albuterol nibs, epinephrine. I mean, every school hopefully now is equipped with epinephrine, and epinephrine is a quick and fast bronchodilator as well. So may not be fun for a patient to get an intramuscular injection, but if you are not allowed to, for example, use a nib based on your school district's policy during the pandemic, epinephrine would be something you could use in an emergency.
Right, and I think too, considering a really well ventilated area, and then the other thing is that this might be something where nurses want to plan ahead and consider having the appropriate PPE or personal protective equipment on hand in the event that they do need to use a nebulizer. And you talk about getting a well ventilated area away from people, and then that it raises the issue of if the nurse is tied up with one student in a secluded area, who's watching all the rest of them? And this really does turn into a question that kind of looks like a big snowball running downhill. So I do think that this would take some brain power at the school district level for you to figure out what it is you want to do. But also, if you're a school nurse and you're asking that question, consider talking to your state school nurse consultant. Most states have one, and it's a person at the state level that helps with guidance and state regulations, and they could probably help you understand, what your state is standing behind as well. Okay, we're back to peak flow meters for our next question from Valerie. She wants to know, at what age should peak flow meters be used in asthma management? Is there an age that's too young?
I think that it depends on, every patient is different, I will say, but they have to be able to perform the maneuver. So, it's a calculation based on their height. And so as long as they can give that strong burst out, and you don't know unless you watch them do it, but it could be late toddler years, sometimes it's early elementary years. So I don't think it's a bad idea if this is something that you are wanting to use to help you gauge your asthmatics. You can try it as early as 4 to 5 years old even. That I think a lot of, I don't say a lot, but there are a portion of kids that age that would be able to perform that maneuver. So I would say, I guess my short answer, probably in 4 to 5 year old range, you may be able to start trying to use it.
Okay, great, thank you. When prescribing increased ICS, and that would be inhaled corticosteroids, at first sign of sickness, the family often asks, when should I stop the controller? In other words, do they take it for 3 days, 4 days, or how many? And there's usually uncertainty among patients.
Per the guideline, the guideline recommends 7 to 10 days. So, if we think about upper respiratory infections, most of the time they're going to last 7 to 14 days before symptoms are totally resolved. So the 7 to 10 day time frame should calm that inflammation in the airway, hopefully enough to accomplish what it's designed to do, which is keep that viral trigger from triggering the exacerbation. I don't think if you needed to go, a week longer, again, using these for these short bursts, I'd rather err on the side of using it longer than shorter. Again, still not having to use it daily for these patients, so the cumulative steroid exposure is still kept to a minimum using this strategy.
Well, I think it's so important to help families understand that ICS is not like an anabolic steroid that we hear about bodybuilders using, because I think so often people hear steroid and that just really makes them nervous.
Right, these are not that type. They are more focused on decreasing inflammation. And the beauty of the inhaled ones is they go directly into the lungs with very little, I won't say zero, but very little absorption into your bloodstream. So they really go to where the problem is. Whereas prednisone, prednisolone, all these oral steroids, these have a lot more systemic exposure and potential for side effects.
Okay, Karen has a question for us next. Please address the difference between RSV and an asthma exacerbation in a child not diagnosed with asthma.
So RSV, respiratory syncytial virus, is an infection that commonly causes bronchiolitis, inflammation of the small airways, and certainly that can appear very similar to asthma, wheezing, somewhat decrease in oxygen saturation, and can be treated similarly with nebulizers, oxygen, etc. There used to be, years ago, some thought of, does RSV infection cause or predispose one to developing asthma? Meaning if somebody does get a severe RSV infection, is that causing their asthma or predisposing them? And there was a lot of controversy of it. And more recently, the consensus seems to have been, it doesn't necessarily cause it, but in those that are predisposed already to develop asthma, be it family history, genetics, environmental things, then those people tend to get worse RSV infections. So it's not a causal relationship, but RSV can be worse in those already inclined to have asthmatic tendencies.
Okay, great. Our next question is that we see a broad range of medications included in asthma action plans issued to school children. Do the asthma action plans that you commonly prepare include antihistamines and nasal sprays, or are they more frequently limited to ICS and rescue medications? What do you prefer or recommend as an asthma specialist?
On the asthma action
Let me know if I need to repeat part of that. That was long.
Oh, no, I got you. On the asthma action plan, I usually limit it to the asthma medications. So any medication that is affecting the symptom that they would be presenting to their school nurse. So they should be taking their preventive inhaler, or they're going to be using their inhaler albuterol as needed at the nurse's office. Though I do address their allergies, because certainly allergies can contribute to asthma, I don't usually include those on the action plan. I try to keep it as streamlined as I can, because I know there is a lot of paperwork that comes to a school nurse's desk every year. And so I don't want to, I want to keep it clear so that when they're going to find whatever it is, it's easier. So I typically limit it to their asthma medications.
Okay, great. Our next question is a very interesting one from Maureen. She asks, are we expecting an uptick in September this year for the September asthma peak due to COVID-19? And what extra measures can be done in schools to prevent this?
So COVID, believe it or not, though initially early on when we were learning about it, there was concern about asthma being a chronic lung disease, quote unquote, and COVID being higher risk in people with chronic lung disease. It has not borne out that way. That we've actually found that asthma actually has not been a risk factor for worsened COVID. And it's not exactly clear why, but the theory is that the allergic kind of immune system skewing may offer some protection. So specifically with asthma and COVID, there's not a whole lot to specifically recommend. So precautions would be for the asthmatic child, take your preventive medications as we recommend anyway. have the action plan there and a plan, and if symptoms were to develop. And then, every school system I know has their own policies on COVID precautions, but whatever those precautions are, those can only help. We're still going to be exposed to common viral infections, although if you are in a school system that does have significant COVID precautions, masking, barriers, distancing, etc., I suspect that these viral infections will continue to be less frequent than in a normal fall and winter school year. So time will tell how this year goes. There's some predictions that flu is going to make a comeback, but again, if COVID is still running rampant and there's still a lot of precautions being taken, masking, distancing, etc., at schools, we'll see. We'll see. It's hard to predict.
Well, this certainly hasn't been a normal year so far. I don't know why we might think that might start.
True.
So next question is, does your practice use a specific asthma self-management curriculum? And if so, which one works best for children under 12?
We don't use a specific curriculum. We do have our action plan. We do have literature that we provide about asthma, but the self-management curriculum per se, we don't use. Sally, do you have information on that or suggestions for that question?
Well, it's interesting that my one big recommendation also comes from St. Louis, just like you. The St. Louis Children's Hospital has a program, it's called AMES, and it's AMES, Asthma Management Education something. But if you just Google AMES, AMES, and asthma, this toolkit from St. Louis Children's Hospital will come up. I'm not sure if that's exactly the kind of thing you're looking for, but if you don't find what you're looking for, you can always email me and I'll help you figure out how to best make that work. Okay, our next question is, this is from a patient. I'm a 68-year-old man who was diagnosed with adult onset asthma 3 years ago. I've been taking Symbicort twice a day. Recently, my doctor agreed I could take only as needed, which over the past 3 months has worked fine. Do you think that I'm probably fine if the last 3 months is any indication? Now, I do understand, Dr. Ketcher, you might be hesitant to answer a specific patient question, but I wanted to just pose this for this patient.
Sure. I appreciate the question. 3 months is a good sign. I would like to see a little bit more of a sample size, but I think that your doctor, based on, especially on these updated guidelines with the SMART therapy, it seemed reasonable. For mild asthmatics, I will say, there's some thought to use this Symbicort or other ICS with formoterol on an as-needed basis. I guess my question for you would be, if you were characterized as a moderate persistent asthmatic, then I'm not sure. It depends if your initial categorization or diagnosis was in fact accurate. If you did have moderate persistent asthma, then the guidelines would say you need to continue on your daily preventive medicine. If on the other hand, you went through a bad stretch and whatever it was, infectious or otherwise, got better, and now you're doing okay, then you may get away with as needed. So a little difficult to give you concrete recommendations, but I will just say it seems like a good sign that you're doing fine over the last 3 months. But beyond that, I can't really give you any definitive answers.
Okay, and our last question for today is, students often show up at school with their inhalers, but they don't tend to have a valved holding chamber. Is there any way we can help families get a valved holding chamber for use at school?
So it can be somewhat challenging to know where to get it. Some pharmacies provide them and a prescription will do it, and then some of them don't. And so we end up having to send an order to a durable medical equipment company. So essentially, you want a valve holding chamber to be somebody's personal. You can't really share them. So every asthmatic, if I was a school nurse, I think it would be a reasonable thing to discuss with the parent. Can we get one of these? And then the parent would then have to address it with the provider that's treating the asthma. There are, I will say, some of the pharmaceutical companies in the past have given sample valve holding chambers to offices. And so that could be something to pursue on a school level or something, even a district or even a state level by chance. But an ideal world, I think every, at least elementary patient, every elementary school patient, and probably all pediatric patients would ideally have a valve holding chamber to use with their HFA inhaler, just because, again, it just really helps, in my experience at least, really helps get that medicine into the lungs where it needs to work.
Well, thank you so much, Dr. Ketcher. Appreciate so many answers to so many questions. And I'd like to thank our participants also for joining us today. At this time, please download your certificate of attendance from your control panel. If you have any difficulties, please email us using the link in your emails. Please join us next month as we look at asthma in the yellow zone. This webinar will air on Thursday, September 23rd at 4:00 p.m. Eastern. You can register for this webinar on our website at allergyasthmanetwork.org. Look for news in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our recorded webinars on this page on our website. Visit our website for quality, guidelines-based resources on allergy and asthma. Also access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network. We're working every day to breathe better together through the September Asthma Peak.